Welcome to everybody attending this webinar that is part of the World Mitochondrial Awareness webinar series organized around the thematic week on the third week of this month. We have a very well-known speaker, but we still need to introduce him. So Professor Mancuso is a neurologist at the Neurological Clinic of Cisanello Hospital and Associate Professor of Neurology at the University of Pisa. He has roles not only in neuromuscular genetic diseases, but also in mitochondrial diseases and cerebrovascular diseases. Is the coordinator of the Clinical Neurogenetics and Rare Diseases of the Italian Society of Neurology and of the Neurogenetics Working Group of the European Academy of Neurology. He's also the chairman of the mitochondrial group of the EURO-NMD, together with Cornelia Kronblum, and also coordinating the new inter-ERN group on mitochondrial diseases that lumps together rare neurological disorders, eye, epicare, and neuromuscular diseases. As you may know, but I should have said first, these webinars are a collaboration between the European Reference Networks for rare neurological disorders, for epilepsy, rare epileptic disorders, and the European Academy of Neurology, and finally, the European Reference Network for Neuromuscular Diseases. And so without further ado, I thank Michelangelo for kindly accepting to start this webinar series, and the floor is yours.
Thank you, Antonio, and thank you very much for all the people who are with us online. And as usual in our webinars, at the end, you can always, also during the webinar, you can write your questions in the chat, and at the end of the webinar, I will try to reply to all the questions that we will collect. So as Antonio already mentioned, this is the first webinar organized by the Mitochondrial Working Group in collaboration with the NMD, Rare Disease, Epicare, European Academy of Neurology. And this working group I'm coordinating with the Connie that you can see here in the bottom. And just to double check, maybe you're not aware of all the other webinars. Here you can see the other webinars that are planned during September, because in September we have the Mitochondrial World Awareness Week, which is a traditional week dedicated to the awareness of mitochondrial disease. So if you go either on the NMD webpage or the European Academy webpage, I mean, you will find the way how to do the registration and join the other webinars. So a brief introduction for who is not very familiar with mitochondrial diseases. Mitochondria are the powerhouse of the cells. Basically, into the mitochondria, we have all the possible biochemical pathways that at the end basically allow the respiratory chain machinery, this beautiful 5 complexes that I'm showing you now with my pointer. And here, basically at the end, we will burn the oxygen and the fatty acid to produce ATP. And during this process, we not only produce ATP, but we transform oxygen in water. We produce a little amount of ROS. And this is the reason why mitochondria are very important, because we breathe through the mitochondria, and the mitochondrion is the one who produces the ATP for the cell. Mitochondrion is the only organelle that has a specific DNA, the mitochondrial DNA, which is a very small molecule. we have basically a combination into the mitochondria of different proteins that are encoded either by the mitochondrial DNA, but most of them will be encoded by genes from the nuclear DNA, which are then transferred into the mitochondria. At the end, we will have a mitochondrial disease if we have a mutation in the mitochondrial DNA, but also if we have mutation in genes localized in the nuclear DNA, which will follow Mendelian inheritance. Because the mitochondria are everywhere, theoretically all organs may be affected. This is the reason why we always talk about mitochondrial medicine, because from a clinical point of view, we may have clinical manifestation. Of course, brain, heart, and skeletal muscles are the most affected, but we may have mitochondrial dysfunction and organ failure from the head to the bottom of the foot. Mitochondrial disease are not rare because we now know that the prevalence is at least 1 every 5,000 people, maybe more. So it's something that for sure everybody will be dealing with during the clinical basically duty. We will talk today about mitochondrial epilepsy, and we know that approximately 20–50% of mitochondrial disease patients will have seizures, and we will see that epileptic seizures may be the presenting feature of a mitochondrial disease, or it can appear during the disease course. It can be clinical manifestation in the childhood or also in a very late age. Virtually any seizure semiology and different seizure combination may occur during the development of the mitochondrial disease, even though the classical absent seizure will see that this is very, very rare. Why we have epilepsy, mitochondrial disease? Why most of our patients will develop mitochondrial disease? Well, there are multiple reasons that are summarized in this cartoon and the following one. Both neurons and glia are extremely vulnerable to the effects of ROS that I say at the beginning are normally produced into the mitochondria. But when we have a mitochondrial dysfunction, we have an abnormal production of ROS. And of course, we have depletion of ATP synthesis in the mitochondrion. So both situation, ATP deficiency and ROS accumulation, will lead to an abnormal function of both neurons and glia. We will have an abnormal excitability of the neurons. We will see later that we also have an impairment of GABA, we have an impairment of glutamate, and all these reasons will lead to seizures in our mitochondrial brain. So at the end, the energy depletion, the oxidative stress are probably the two major pathogenetic moments in the development of seizures in mitochondrial disease. But from these two major points, we will have impairment of calcium, sodium, homeostasis. We will have an impairment of the neurotransmitters. All this will lead to hyperexcitability of the neurons and eventually seizures. We know that ROS are extremely important, not only as a pathogenic moment of mitochondrial epilepsy, but there are brain models that clearly demonstrate that also in let's say sporadic or not mitochondrial epilepsy, mainly temporal lobe epilepsy, we have a ROS accumulation and secondary mitochondrial involvement. So this aspect, ROS and mitochondrial dysfunction, is also very important in other epileptic conditions. Another very interesting role that we have in mitochondrial dysfunction, it's also the impairment on astrocytes function. Also, this one was clearly demonstrated in elegant animal models. And not only we have from the neurons compartment hyperexcitability, we have dysfunction of the inhibitory interneurons, but also in the glia, what we observe, we have, because of the ATP depletion, because of the ROS accumulation, we have a dysfunction and as mainly a downregulation of the glutamine synthase into the astrocytes, which at the end will lead in a depletion of GABA, which we know very well is extremely important in controlling the hyperexcitability of the neurons. So because of both dysfunction, neuronal and the astrocytes in different ways, we will have predisposition to seizures in mitochondrial disease. Well, when we talk about epilepsy in mitochondrial diseases, we have several, let's say, epileptic enigmas here, and we will go through this. Why several genes in mitochondrial disease are more prone to epilepsy? I said at the beginning that we may have a mitochondrial disease caused by mitochondrial DNA gene mutations. We may have a mitochondrial disease caused by mutation in one of the hundreds, and we calculate almost 1,500 different genes in the nucleus that encode for something that is useful for mitochondrial machinery. But not all genes are usually leading to epilepsy, and this is not very clear so far. Why also several mitochondrial phenotypes are more prone to epilepsy? For instance, if we take the Leber optic neuropathy, usually we don't have epilepsy, while if we take the Milas syndrome or the MERV syndrome, we will see epilepsy is the extremely common manifestation. And so if we take different mitochondrial phenotypes, not always we will observe seizures. And if we deal with biochemical dysfunction in the mitochondrion, we now know that complex 1 is deficiency when we have a mutation which impair mainly complex 1. For most likely, we will have seizures, while if we have a mutation going to impair, for instance, only complex 3, we will not have, most of the time, we will not have epilepsy. And this is not clear. And at the same time, we have genes that not only are more prone to be associated with epilepsy, but we also have some genes that are more prone to develop severe epilepsy and status epilepticus. And this is another enigma, not sure why this is happening. And at the end, why some areas of the brain are more prone to develop seizures activity. And we will see also stroke-like episodes that are lesions in the brain that we will discuss later on. So to go through the topic of today, what I'm going to do, also for a question of time, I will try to cover the epileptic phenotypes, referring mainly to the cohort studies so far published and to my personal experience. And then I will also cover specific mitochondrial disease syndromes specifically associated with epilepsy. And I will mainly talk about Milas, MERV, and the POLG-related mitochondrial disease. So as I mentioned at the beginning, we may have all kinds of epileptic seizures in mitochondrial disease, even though the classical absence seizures with the 3 per second spikes waves usually are very rare, but beside the absence seizure, the classical absence seizure, we may have really all possible epileptic semiology in mitochondrial disease. So we have so far 2 big studies exploring the prevalence and the clinical features of epilepsy in mitochondrial disease. We have the first study coming from UK, mainly from the group of Newcastle, with also data from London. And then we have a study that was published in Italy and this is basically the Italian situation. That is the second paper that we have so far with big numbers in the literature. So the first study from the Newcastle group, this is not covering the entire population they have in UK. They were analyzing 182 adult patients, and of these 182 patients, they found 42 patients who developed during the disease course epilepsy. Epilepsy in this cohort was a common manifestation. At the end, the prevalence in this group is 23% of their population. In this study, they observed that epilepsy developed early in the disease, and especially in the case of the mutation 3242 in the mitochondrial DNA, the mutation which is frequently associated with MELAS. Epilepsy is most of the time associated and present in the context of a stroke-like episode or status epilepticus. The overall prevalence in the UK is 23%, and here is one of the first enigma that I was introducing before. Within their patient with mitochondrial disease, there were genes, basically OPA1, PO1, or these are nuclear genes, or other mitochondrial DNA point mutation like the 14709 that never lead to epilepsy. In the contrary, if we observe and we focus our attention in the most common mitochondrial DNA mutation, mainly the 3243 mutation, but also the 8344 mutation. In this case, if you have this mutation, the probability of developing epilepsy is quite high. You can see here that 35% of patients with 3243 have epilepsy, while almost all patients harboring the mutation 8344, at the end, they will develop some kind of epileptic seizure during the disease course. So these two genes are extremely linked to the risk of developing epilepsy. Regarding the seizures phenotype, a wide range was observed, and most of the time, patients were also manifesting different seizure types. In particular, the 8344, most of them, they have epilepsy with myoclonic jerks. And as you can see here, I hope from this figure coming from their paper, at the end, most of the patients, again, here on the left, are affected by either the 3243 or the 8344 mutation. And when we look at the phenotype of the seizure type, we may have a focal seizure. They can be either motor or sensory seizures. We may have myoclonia. We may have generalized tonic-clonic seizures. We may have status epilepticus as first manifestation, most of the time associated with the stroke-like episode, and I will come back to this later. The Italian study, the difference is that here we have analyzed the prevalence of epilepsy in the entire cohort of our patients registered in the web-based registry of the Italian network. Therefore, considering the entire population, the prevalence in Italy is exactly 10%, because we have almost 150 patients with epilepsy. This is not a lower prevalence compared to the previous one, because, as I said, the previous study was not related to the entire cohort of mitochondrial disease patients followed in UK. Here we have a lot of patients, for instance, with Leber that will never develop epilepsy, as I said at the beginning. So if we analyze our data filtering the data, removing, for instance, only the Leber patient, we will jump up to 15–18% of prevalence of epileptic seizure in our population. Epilepsy in Italy was the presenting feature in almost 50% of our case, with the onset at the median age of 19 years. But you can see the range here is from basically birth to 68 years of age. Here is another difference with the previous study, because the previous study was only analyzing epilepsy in adult population. Our study was covering both early onset childhood and late onset adult onset patient with mitochondrial disease. This is the reason why we have more data also on the severity and progression on epilepsy. We have observed, for instance, that individuals with early onset epilepsy, meaning that the epilepsy onset was below 3 years of age, had a significantly higher probability of displaying seizures of unknown onset as the first seizure type, spasm and tonic seizures during the disease course. They also have the probability to have higher frequency of seizures compared to those individuals who develop epilepsy in at the adult age. Adult onset of epilepsy was more associated with myoclonus as first type of generalized seizures, and considering also the EEG features in our Italian cohort, we found that individuals with early onset epilepsy more frequently displayed abnormal background activity in their EEG. Mainly, we observe a disorganized pattern. Here you can see more in details our data. This is the distribution of epilepsy in our Italian cohort. You can see that we have almost 50% of epilepsy started before 3 years of age, and then we have some case with adult onset, so it's less common, and then we have intermediate onset, so between 3 and 90 years of age. Regarding the genotype, it's quite small, but believe me, here in Italy is basically the same that was observed in UK. The 3 most common genotypes associated with epilepsy are the point mutation 3243, the point mutation 8344, and the mutation in POLG. So these 3 are again the most common genes leading to epilepsy. This is very important also when we do the diagnosis, because when we talk to the patient and the family, especially if they are children, we may know, as commonly happens in mitochondrial disease, they may develop other symptoms, other signs, including epilepsy, including seizures. So EEG and the brain health must be monitored in this patient. Patients may have also in Italy all different kinds of seizures. We don't have a specific pattern from seizures type. And most of our patients, as you can see here in C and D, develop epilepsy in a context of multi-system disease. So another important point to keep in mind is that when we have a patient with mitochondrial disease, epilepsy very rarely is the only problem. Most of the patients will have different signs of different organs dysfunction, and this is because the mitochondria are everywhere, and the mitochondrial mutation most likely is everywhere. Here you can see, for instance, what I was saying before, the distribution of seizures type in individual experiencing a single episode of seizures. And again, here we don't have a specific pattern. We may have different seizure semiology. Therefore, we don't have a pathognomonic seizures type in our patients. We may observe focal, generalized. They may be tonic-clonic epilepsy. We may have mainly in early infancy spasms, and also unclassified seizures. Here, let's see how can I, because my slides is covered by the Zoom functions. I don't see everything, but basically what we observed here, if I remember correctly, is that age at onset was found, of the seizures, of course, was found to be significantly different between individuals harboring nuclear DNA mutation and those harboring mitochondrial DNA mutation. Most of the time, children with mutation in the nucleus have a multisystem severe encephalopathy and the Lee-like syndromes, where epilepsy is extremely common. Overall, individuals with a mutation in nuclear genes are more likely to have a history of tonic seizures during the course of epilepsy, more seizures in terms of recurrence, and are also more likely to have a disorganized EEG background activity. And again, mainly these are children with Lee-like syndrome or other encephalopathies caused by nuclear genes. Vice versa, patients with mitochondrial DNA mutations more frequently presented dysfunction affecting also sensory organs and also other organs, including the heart, the skeletal muscle, and so on. So considering the entire mitochondrial disease population, we have seen that at the end, we may have epilepsy up to 20% at least of mitochondrial disease patients. We may observe all different types of seizures, but we also have seen from these two cohort studies that we have sorry, just give me a second. Antonio, you want to say something? Sorry.
No, I'm fine.
Sorry.
Do you need any help?
No. I don't know why something was flashing on my computer. Sorry.
Don't worry.
Okay, sorry. So going back to the genotype, as you have seen from cohort studies, big numbers in Italy at least, but also in UK, at the end, most of the time, we have three genotypes that are considered hotspots for mitochondrial epilepsy. And we will cover now more in details these three genotypes. We will start with the 3243 mutation. This is the cause of MELAS, meaning that 80% of the times when we have a MELAS syndrome, we will find the 3243 mutation. But please you have to understand that this is not synonymous that if you have a 3243 mutation, you will develop MELAS. That's a different story. If you have a MELAS, most likely you harbor the 3243 mutation. But if you have the 3243 mutation, this doesn't mean that for sure you will develop MELAS. The 8344, I will talk about the MERF syndrome, because here, as in MELAS, MERF is 90% of the time caused by this mutation. And then we will cover a little bit also POLG. So MELAS is this multi-system, multi-organ disease with a broad manifestation. We have basically in all our patients a multi-system, multi-organ failure, but as the name says, the dominant sign of the MELAS is the stroke-like episode. Epilepsy is a common manifestation in patients with the MELAS. We will see, depending on the cohort, that we can have epilepsy in 70% of patients with MELAS, up to 95% of patients with MELAS, so an extreme common manifestation. And the semiology of epilepsy in MELAS is quite heterogeneous. And we will see again later, the stroke-like episode is the main clinical lesion we observe during the MELAS acute failure, and this is driven by epileptic activity. Primary generalized seizures in MELAS can be associated with normal neuroimaging, but most of the time, a patient with MELAS will develop either stroke-like episode, as I mentioned, but they will develop during the disease course, white matter lesion, cortical atrophy, cortical necrosis, and therefore at the end we will have also a progression of the encephalopathy in the disease course. So it's very rare that during the disease course the brain MRI will remain forever normal. This is a typical, sorry, a typical example of a lesion of a stroke-like episode. Stroke-like episodes are these metabolic strokes driven by seizure activity. They do not respect the artery, the major artery distribution in the brain. You will never find a lesion that will follow the internal carotid or the middle cerebral artery distribution. Most of the time, these lesions are localized posterior in the occipital lobes, but also in the temporal lobes, but they can spread and migrate everywhere during the acute phase of the MELAS. This is a study from Japan, where they observed almost 100 patients with MELAS, and they observed in Japan that among the clinical symptoms at onset or also during the disease course, seizures and headache were extremely common, and they were associated, as I mentioned, with stroke-like episodes, both in the juvenile form and in the adult form. Focal seizure and status epilepticus are extremely common again in patients with MELAS, but again, while in 3243 mutation, usually without a clear MELAS phenotype, the prevalence, the risk of develop epilepsy will be around 25%. If you have a 3243 mutation leading to a MELAS phenotype, you can say to the family, to the patient, that the probability of developing epilepsy is absolutely more than 50%, but most of the cases is above 70, 80% of probability of developing epilepsy. In MELAS, the semiology of the seizures is again unpredictable. They may have different seizures during the disease course. Very common to have provoked metabolic seizures during fever or during the fasting, on where we have, for instance, hyponatremia. Focal onset seizures may caused by the sequelae of prior stroke-like episodes. The stroke-like episode usually at the very beginning, at the early stage of the disease, may resolve without leaving lesions, but during the disease course, the recurrence of these metabolic strokes, of this metabolic crisis, will lead to atrophy, gliosis, and therefore this will be also trigger for focal seizures. However, again, please keep in mind that the most pathognomonic seizures in MELAS is the stroke-like episode, because this event, the stroke-like episode, is a metabolic stroke caused by seizure activity in the underlying neurons that are experiencing an energetic crisis that sometimes is triggered by, as I said, hypoglycemia, fever, stress, fasting, and so on. Okay, this is very important. Just to try to explain why 3243 is not synonymous of MELAS, therefore why it's always important when you do the genetic diagnosis in patients with mitochondrial disease, you must be very, very clever because not always the same mutation is the cause of the common phenotypes. We are used to imagine that the 3243 has a MELAS mutation, but this is not always the case. And for instance, we were, just to give you a demonstration of what I'm saying, we were analyzing the features of the 3243 patients in Italy a few years ago. This is in Italy the most common mutation, as in most of the countries. And you can see here that patients with seizures will for sure develop seizures. As I said, the white here is at the onset, and the black is the percentage of patients that develop one of these signs during the disease course. So you can see that at least in Italy, up to 40% of the patients harboring the 3243 mutation will develop epilepsy, but the stroke-like episodes is not always linked to the 3243 mutation. In Italy, we have, let's say, only 40% of patients with the 3243 mutation which will develop stroke-like episode. In 60% of the cases, we will not have stroke-like episodes in patients with 3243 mutation. So when you do the diagnosis of 3243 mutation, you cannot always say you have a MELAS, because it cannot be the case of your patient. Actually, this can be true in 60% of your patients. If we look together on the prevalence and the prevalence of specific signs on 3243 and also in patients with the 8344 mutation that we will discuss better in the following slides, you can see that most, again, of our patients with the 3243, up to 38%, before I said 40, sorry, may develop generalized seizures. And this is also a very common manifestation of the 8344 mutation. Up to 30% of our patients with the 8344 mutation will develop epilepsy, generalized seizures. But for instance, stroke-like episode is quite pathognomonic of MELAS, is extremely rare in other mitochondrial encephalopathies, including MELAS. Vice versa, myoclonus is more commonly observed in patients with MERV, with 8344 mutation, while it's more rare but not absent in patients harboring the 3243 mutation. Again, just to give you the complexity of mitochondrial disease, for sure, if you have a patient with one of these two mutations, most of them will develop encephalopathy, most of them will develop seizures, epilepsy, but it's not always the case. So we cannot generalize our conclusion, and this is why it's very important to know quite well mitochondrial disease, because it's not always easy to do counseling and deal with the patient, with the families, if you don't know the natural history of all these disorders. Sorry. The other important mutation is the 8344, which is the main cause of MERV, which is myoclonic epilepsy with ragged red fibers. This is much more rare compared to the MELAS, but this is another important mitochondrial disease syndrome. MERV, like MELAS, may be manifest in very early age, but also in the adolescence, but we also see patients that develop the first sign of MERV after 18, 20 years of age. It's another neurodegenerative disease. It's almost impossible to have patients with MERV with normal MRI. Most of them will develop progressive atrophy of the brain, mainly of the cerebellum, but not only. Patients with MERV have not only epilepsy, but they have also ataxia. Most of them have, we'll see, lipomatosis. They have retinitis pigmentosa. They may have hearing loss. And most of the time, this disease will lead to death in our patient, but there are not clear prognostic factors for death, and we have cases that unfortunately passed away in the infancy, but we also have a patient that survived up to almost 80 years of age. So the clinical features of MERS are dominated by definition by the myoclonus epilepsy. We observe most of the time sensory neural hearing loss. The EEG shows typical patterns. Most of our patients have a multisystem disease, like in MILAS. We observe a myopathy. We may observe a heart block or arrhythmia. Most of these patients will develop peripheral neuropathy, and a very common sign in patients with MERF and in general with the 8344 mutation is the presence of peripheral lipomas, which is a very common sign, even though rare, of a mitochondrial disease, mainly MERF, mainly 8344 mutation. We were analyzing the 8344 Italian cohort a few years ago, and what we observed in Italy, but this is true almost everywhere, but in Italy the data was stronger, that at the end, the real association we have here is between myoclonus and cerebellar ataxia, because most of the patients with myoclonus will have epilepsy for sure, but most of the patients that have myoclonus have also cerebellar ataxia. And the association between myoclonus and ataxia is stronger than myoclonus and seizures and epilepsy. And this data was also analyzed a few years after in Germany by the Mitochondrial network coordinated by Thomas Klopstock, with also Cornelia there. And basically they analyzed similar number of patients, they observed similar associations, even though the association, as I said before, between myoclonus and ataxia was a little bit weaker in Germany compared to Italy. The other important gene that leads to epilepsy and that we should keep in mind is the polymerase gamma. This is a nuclear gene which cause most of the time mitochondrial DNA depletion and multiple deletion as a secondary consequence. Patients with POLG most of the time are affected by epilepsy, and frequently epilepsy in POLG is associated with is a severe epilepsy. Most of the time it can be drug resistant, and it's also associated with the higher morbidity and mortality compared to epilepsy that we observe in MILAS and MERF. In POLG, the epileptiform discharge are similar to what we also observe in the MILAS. They can start in the posterior areas of the brain, like in the occipital regions. We may observe focal seizures, but most of the time in POLG, from focal occipital seizures, we develop generalized seizures or convulsive seizures that are more commonly observed in POLG compared, for instance, to MILAS and MERF. We always have generalized seizures and secondary generalized convulsive seizures in MILAS and MERF, but it's more prevalent in POLG. POLG is a very tricky gene, but the same was true for the 32 and 83, because POLG really causes an enormous different phenotypes. We have patients with infantile devastating disorders where, for instance, the Lee syndrome, Lee-like syndrome, but mainly Alpers syndrome. In these patients, most of the time, the polymerase gamma mutation lead to secondary severe mitochondrial DNA depletion, but we may also have autosomal recessive benign POLG mutation that lead only to PIO or primary mitochondrial myopathy, or for instance, only neuropathy or very late Parkinsonism. So this gene is quite difficult to deal with. It's very difficult to do genetic counseling here, and it's very difficult to predict the clinical course. We are very, very unable to forecast the evolution of our Paul-G syndrome in most of our cases, unless we have an Alpers phenotype, which is devastating encephalopathy with the liver failure. So the last 15 minutes, I want to cover briefly the management of mitochondrial epilepsy. Epileptic seizures, as I said, may be the first and also the only sign of mitochondrial dysfunction, and we need to treat them. Sorry. Regarding the drugs, the most commonly used epileptic drugs are the benzodiazepines, levetiracetam, lamotrigine, piracetam, and vigabatrin. The only serial drug that can cause severe problem is valproic acid, which is contraindicated only in Paul-G, meaning that if I have a mutation in Paul-G, we cannot provide valproic acid, because in most of these patients, you have a high risk of developing liver failure. And there were cases of Alpers. I mean, after we realized that this was an Alpers syndrome, but patients with Lee-like syndromes and at birth, that took, I mean, at a very early age, they took valproic acid and they developed acute liver failure, for instance. So if you have a mutation in Paul-G, you cannot use this, contraindicated in Paul-G. If you don't have a Paul-G mutation, if you have, for instance, mutation in 3243, if you have a mutation in the 8344, in this patient, the contraindication is not an absolute contraindication. Worst case scenario, you have tried already multiple drugs that they don't work, so you may use valproic acid, but preferably not in young children and not in those cases where you have already documented a liver involvement, a liver disease. Ketogenic diet, I will come back to this. It can be useful in children. In Italy, I will come back to this. There are not a lot of data on epilepsy surgery or vagal nerve stimulation in mitochondrial diseases. So the few cases that were treated with both either surgery or VARC stimulator, they didn't really work well in those patients. And of course, while we treat epilepsy, we have also to try to give some mitochondrial cocktail to our patient. This is not mandatory. This is not demonstrated it works, but mainly when we have complex 1 deficiency, idebenone is a good option to use. So our experience, going back to the Italian network paper, what we have observed is that in Italy, at least in our experience, epilepsy can be controlled in most of the cases. We have only 11% of patients in Italy that didn't respond to the anti-epileptic drugs. The response to treatment seems to be not influenced by age or epilepsy phenotype or onset, even though we know that patients with nuclear DNA genes are more, some nuclear DNA genes with very early onset may have more severe epilepsy and more complex epilepsy to treat with drugs compared to later onset and point mutation in the mitochondrial DNA. The drugs we use in Italy, basically, we didn't observe any spatial problem related to the mitochondrial dysfunction. You know, the legend of mitochondrial toxicity of drugs in general. I will show you later another point. We may easily use in all our epileptic mitochondrial patients gabapentin, lamotrigine, zonisamide, levetiracetam, benzos, and no problem. And in Italy, at least, levetiracetam is the most antiepileptic used, mainly in adults. while in children, the most used drugs were phenobarbital and vigabatrin with good seizures control, as you can see, 75 and 66% respectively. And here you can see, but it's quite boring here, but it's very useful. If you go into the paper, it's an open access paper. You can see all the drugs we have used in Italy, what age, and the the efficacy of each drug used in our Italian cohort. So if we have a mutation in POLG, we don't have to use valproic acid, and we know that the risk of valproic acid is linked to the fact that valproic acid influence and inhibits the fatty acid beta oxidation into the mitochondria. Okay, so what about the ketogenic diet? Ketogenic diet in Italy, our experience is that who was treated, mainly children with ketogenic diet, didn't really observe a specific benefit under ketogenic diet. And for this is a very recent review that you can read, analyzing all the very few data around in the literature regarding ketogenic diet and mitochondrial disease. But here, basically, the conclusion was that we don't have enough data to promote ketogenic diet in mitochondrial disease. But while I was preparing the last slides, a few days ago, this paper came out from China with Fang, that is the the director of the Children's Hospital, University Children's Hospital in Beijing. They know very well. They are very serious people. They published very recently, a few days ago, this paper on effect of ketogenic diet in mitochondrial epilepsy. They were planning to enroll 96 patients, but then at the end they had problems. I don't know if this was caused by the COVID or something else. And so at the end they randomized 22 patients to ketogenic diet for 3 months. And then they randomized 11 patients to one month of normal diet, followed by 3 months of ketogenic diet. What they have observed, that after 1 month, patients under ketogenic diet experience at least 50% reduction of seizures, and 1 patient became seizure-free, while only 18 patients under standard antiepileptic drug without ketogenic diet, only 2 patients improved. But once this control group was shifted to ketogenic diet, after 1 month, from 18%, 63% became experience more than 50% reduction of seizures. And in 1 case, they observed seizure-free. And after 3 months, these data were even better compared to the first months. Patients that were studied in China, at least most of the benefit that they have observed was linked to those epilepsies that are caused by 3243 mutation. Here, the response was dramatically, was 93% of patients experienced reduction in the seizures, and some patients also seizure-free, while patients with the nuclear DNA mutation, again, as I already say, that most of the children here are children with nuclear DNA mutation and severe early onset encephalopathy, mainly Lee syndromes or Lee-like syndrome, have a worse prognosis in terms of also of epilepsy, and also in terms of response to ketogenic diet, that they didn't respond well. So apparently patients with MILAS, with the 3243 mutation, apparently in this preliminary study in China, seem to respond to ketogenic diet. Then we have general recommendations that you can read that they were published either by the Mitochondrial Medicine Society regarding the care, including the care of epilepsy. But we also recently published the consensus-based statement regarding the management of the mitochondrial stroke-like episodes. And this is a very important document because it's very complicated to treat and manage the stroke-like episodes. You can find in this consensus paper the management of the stroke-like episodes. So we don't need to use, of course, fibrinolysis of antiplatelets because this is a metabolic stroke driven by seizure activity. So we need to treat the patient with intravenous antiepileptic drugs, mainly levetiracetam, benzos, or lacosamide. Okay, midazolam in this patient is the first choice for the anesthetic, mainly when we have refractory status epilepticus associated with stroke-like episode, while Europe don't endorse the use of intravenous L-arginine to treat stroke-like episodes. Okay, this is the general management of the acute phase of MELAS that you can eventually read in the paper. I have to close in 5 minutes. So we have to treat the focal seizures. If we suspect that the patient has a focal seizure, a stroke-like episode, we should perform EEG and also the brain MRI and start immediately the antiepileptic drugs. If we don't have the way to perform an EEG MRI, if we know the patient is a MELAS patient, if we suspect that this is a stroke-like episode, the paresis, the clonic jerks, the hallucinations, for instance, we may start the treatment with the antiepileptic drugs even without EEG or MRI of the brain. MERS is more severe in terms of phenotype, but here we can also use the same drugs that I was mentioning before without problems. I mean, the side effect and all the other things are the same that we have in non-mitochondrial patients. So we apply the rules that we always apply to treat patients with epilepsy. So we can use all our drugs without problems. If we have a status epilepticus, of course, this is more common in MELAS and mainly in POLG. And for us, the first choice is try to start at least with midazolam or lorazepam and eventually use the barbiturates, and also we can use safely, if necessary, the propofol. Please avoid valproic acid in POLG, and in some cases has been reported a benefit with magnesium infusion in super-refractory status epilepticus. If you want to learn more about safety of drug use in mitochondrial disease, including all the anti-epileptic drugs, this was analyzed by a consensus Delphi-based process a couple of years ago from the European community. And so you can see here that all the experts say that we can safely use all our anti-epileptic drugs, including propofol, is safe up to 48 hours. Also ketamine and worst case scenario can be used. So in conclusion, seizures and epileptic status represent one of the most frequent symptoms of mitochondrial diseases. Pathophysiology of mitochondrial epilepsy is not totally understood, but the role of mitochondrial defects in the development of seizures is confirmed mainly through ATP depletion, ROS accumulation, depletion of GABA, impairment of neurotransmitters. Patients with specific genotypes are more at risk to show seizures in their life than others and need to be followed up to prevent these events and try to minimize all the trigger events that could lead to seizures in this patient. And the management and treatment of epilepsy in mitochondrial disease need to be better investigated and personalized for each patient. But we know for sure that we may use all our armamentarium, but valproic acid in POLG, including the most common use anesthetic agents were needed. So this is my last slide. I want to thank both the ERNs and the European Academy of Neurology to have accepted this cycle of webinars that we are, that today we started, and the 3 more are coming. And here you can see all the different people that are collaborating with me in Europe, in Italy, and a special thank to the group in Pisa coordinated by Gabriele Siciliano. So Antonio, I think this is enough. I'm perfectly on time. Thank you.
Yes, that's it. Thank you very much. And it was a very interesting presentation with almost a kind of precision medicine address, in the sense that we discussed genotypes on the side of the phenotypes and draw conclusions and implications for the treatment. So one of the attendees, Monad Saleh, had his hand raised a few moments ago. I suppose he wants to put a question.
Francesco, you can. I think you can also talk live if you are still around. No, or I can read the question.
No. Francesco is still not. Now he can talk. So Francesco, since Monad has not come forward, would you like to put your question yourself?
Anyway, the first question from Francesco.
Yeah, go ahead, please.
Yeah, because I cannot hear him, so I will read the question. So, do the anti-seizure medication prevent the occurrence of stroke-like episodes? Unfortunately not. This is still a progressive disease that we cannot. Okay, Francesco, don't worry. So, unfortunately, no, we cannot prevent and predict the recurrence of stroke-like episodes with anti-epileptic seizures, but the response of the stroke-like episodes, mainly at the beginning of the disease, not at the very late stage, is quite good if you start immediately the anti-epileptic drugs, because the underlying mechanism is driven by seizure activity. And then, do less serious incomplete phenotypes of epilepsy with underlying mitochondrial disease exist? When do we have to advise the patient for a genetic consult or test if we work in a first seizure clinic? Okay, this is a very important point, because one thing that you already deal with the patient with the diagnosis of mitochondrial disease, and so it's okay, it's much easier, let's say. But the point is that we may find patient with mitochondrial disease in the epileptic clinic, and we will see in one of the next webinar. Also, we will find mitochondrial disease patient also in the movement disorder clinic, because movement disorder is another very common manifestation. So when to think about mitochondrial etiology in the epilepsy clinic? Well, I would say when you have a patient with 2 or more organs affected and you have no clear explanation of why you have 2 organs involved in your patient, the first cause is always a mitochondrial disease. Always. If it's not a mitochondrial disease, it can be a lysosomal patient or another metabolic patient, but most of the time it's a mitochondrial patient. So first of all, look beyond the brain and try to find another sign, another organ affected. If you have a pure encephalopathy, you have to think about mitochondrial etiology, mainly when epilepsy is associated with, I would say, cerebellar ataxia. When you have, I'm talking about now clinical signs, so cerebellar ataxia, hearing loss, or for instance, retinitis pigmentosa. Looking at the brain imaging, most of the patients with Mills or MERF will have SOVRA or subtotentorial atrophy, cerebellar atrophy. So if you observe atrophy, and of course, if you work in a center where you can perform spectroscopy, another good way to go is to do the proton spectroscopy of the brain, and you may find the lactate peak, which is very suggestive of mitochondrial disease.
So let me be a bit provocative. If I have an epilepsy patient in a systemic presentation with more than one sign or symptom, as you were saying, can I ask for a panel of 3243, 8344, and pole 1?
I mean, 3344, 3343 and 8344, Antonio, is you do in 3 hours. So when
Yes.
you have a suspect, we go directly to these 2 mutations, and you know, the day after you have the diagnosis if positive. If it's negative, what we suggest, if you have a suspect of Milas, if 3243 is negative, you go through Pol G first, unless your lab is super fast and you can do NGS or exome in 1 week. But most of the time it's not like this. So you go from 3243, you do the Pol G. If Pol G is negative, you start thinking about exome or panel of mitochondrial DNA and nuclear mitochondrial genes, and also muscle biopsy in that case could be important.
Okay. I don't see more questions at the moment, and we are a bit late on time, not too much. We are okay.
Yeah.
And I would like to thank you very much, because I think it was a very good start to this series of webinars. It was a very interesting and a very information-filled webinar, and I hope that people will gather lots of benefits from it. I suppose they will. I'm sure I did. So we are happy with this hour that we spent listening to you. Thank you very much, Michelangelo.
Thank you, Antonio, and thank you again to all the attendees and to the ERNs and to the European Academy of Neurology. So we will be all together again for the next webinar. Thank you.
Yes. See you soon. Thank you.
Okay. Bye-bye.